I'm Virginia Sybert, and this is a little bit of an unusual situation for me in that I'm speaking to the camera as well as to the people in the room. So if I don't do it correctly, please forgive me. We're getting some more people in here right now. I'm from the University of Washington in Seattle, Washington, the United States of America. I apologize for Mr. Trump, and let's not move any. We're not going to go that direction. But I'm here, delighted to be here. Really, it's an honor to be allowed to present the last 40 years of experience that we've had at our institution with Turner syndrome. So that's it.
Thank you.
Okay.
Yes. We can't communicate. So unfortunately, we can't welcome you in person.
But we can wave.
We can wave, yes. Okay. So regarding the program, we are now looking forward to a formal talk till about 10:45, and followed by questions that you can send in. And we also have more time actually till about at least 11:30. But I think we take a break after 45 minutes to see if there are some questions, and then we can continue. And if some of the students have to leave, then yeah, it's a pity for them. Yeah. Okay, so welcome.
So the first thing that I want to say, and I'll say it to you and also to the camera, is that everything that I'm going to present to you is a matter of opinion, and it's a matter of opinion that's based on my experience. I'm the eldest of 6 children. I have a very dogmatic tone of voice, so it will sound as if I am proscribing, but in fact, much of what I'm going to say, I still question. I have great doubts. Every day I wake up in doubt that what I think I know is really what I know. So I'm going to present to you sort of the data that we have and my interpretation of that, but I think in the end you'll realize that there's more that we don't know than that we do know. And if I sound like this is absolutely the right thing, please don't hesitate to tell me that I'm incorrect. So what I'm really going to present to you today is the last 40 years of experience in taking care of both girls and women with Turner syndrome. And okay, we should be able to do this more easily. Hold on a second. Let's do this. Technical problems here next. Okay.
Yeah.
So this is the basis for my biases. And the other thing is that I speak extremely quickly, and I speak in English, which you all speak beautifully, but is not your native language. My Norwegian is limited to tak. So if I do say something that's, if I'm speaking too quickly or it's not clear, please slow me down, stop me, and I'm happy to back down a little bit. So when I first came to Seattle in 1977 to work with Judy Hall, who is a medical geneticist and also trained as an endocrinologist, Judy was very, very interested in Turner syndrome, and she was interested in the natural history of disorders. So for sort of like your center here, she was interested in many rare disorders and sort of what happened to people over time. And she recognized that we knew a reasonable amount about Turner syndrome in infancy and in childhood, but almost nothing about what happened to these patients when they were adults. Sort of, as what often happens, people with congenital disorders get a lot of attention and a lot of treatment in childhood, and then once they reach adult life, they kind of fall off the radar. And so what we did at that point when I came to do my fellowship is wrote a grant which established a clinic specifically to look at adult women with Turner syndrome. And so we recruited adult women. What we tried to do was we put advertisements in newspapers. We wrote to all of the pediatricians, internal medicine, and family doctors in Washington State and tried to recruit adult women to come to our clinic. And the clinic is free for the first 5 years that we did the clinic, and subsequently was not free, which makes a big difference because in our country, in my country, of course, you have to pay for medical care. And to ask people to participate in research, when they have to pay for it is not usually very functional. So we did all these different things I realized gesturing with my hands to the screen is not going to be helpful to anybody, so let me get the arrow here. But we used all these different ways to try to get patients to come to the clinic. I am a clinical person. I am not a laboratory person. This is my laboratory. These are the files. I have 3 filing cabinets of files of all the medical records of the patients that we've seen over the years, and this lives in my house, so spend a fair amount of time there. So I'm going to talk a little bit about the clinic population and really to explain to you why the data that I'm presenting to you are still really sadly lacking. So, and throughout this entire presentation, I will be showing pictures of my patients, which really to humanize this talk, because all of the numbers that I'm talking about really break down into single individuals. Every single one of these people is a human being and a person. And I'm lecturing to the converted. You all know that because of the work that you do. So if you just look at this slide, we have in our database now, and I say we, although this is something that I've maintained for the last number of years, nothing that I've done has been done alone. Everything that I've done, I've had colleagues to help me and patients to help me, colleagues around the world and colleagues at my own institution. So, there's nothing that I've done without an enormous amount of help from a great number of people. We have in our clinic population, in our database, we have information on about 680 patients who carry a diagnosis of Turner syndrome, but 639 who are karyotype proven. So I have the information, but I don't analyze information on women who were diagnosed by buccal smear. These are much older women who never had subsequent karyotyping, or even women who come to me in adult life with a diagnosis of Turner syndrome. They clearly have Turner syndrome, but they don't have their karyotype and they don't have access to it. I don't include them in the data because we try to keep it really clean. But in terms of the data that we have, this is the age distribution of the patients for whom we have data. So based on the last time that I saw them. And you can see there's a preponderance of women under the age of 18. So half of the patients are still were under the age of 18 at the time that we had information. And we may have information from the time they were born until the time that they were 18, but not beyond that point. Again, you see that in the older age groups, we have fewer and fewer women. If you look at the ages that they actually are now, that distribution has really changed. And I'm currently in the process over the next few years of trying to recontact all of our patients. Well, about 300 of the women I have intermittent contact with, and so I've been able to keep up with what's happened to them. But for over half of them, we don't know what's happened to them since the last time that I saw them, which may have been when they were children. So we're trying to get all of that information so that we can ultimately have much more information about women in their 60s and their 70s, because we just don't have very much of that right now. So again, I've been extraordinarily privileged to be able to do this work for a long period of time and to be able to watch my patients grow up and sort of photo document their movement from childhood into adult life. Okay, so the top row are the first time I saw these patients, and then as they've gotten older. So in terms of the clinic population itself, whether it's representative of Turner syndrome, there's certainly bias of ascertainment. First of all, if you don't know your diagnosis, you're never going to come to a specialty clinic. People come for a variety of different reasons. We think that because of the way that we've ascertained patients, so if you're an endocrinologist, you're going to be seeing patients when they get referred for shortness. You're not going to be seeing them when they're born and they're puffy. If you are a gynecologist, you're going to be seeing the young, the 16 and 17-year-old women who are presenting with failure of entering puberty, or endocrinologists as well. Or you'll be seeing the 30-year-old woman with premature ovarian failure. So your view of what the important things in a disorder are, what the major problems are, really is based on how they come to you, what your particular specialty is. And because we've tried to access our patients in a variety of different ways, we think it's a fairly unbiased group, so that they should represent all of the different kinds of problems that can occur in Turner syndrome in the spectrum. In terms of ethnicity, we're a very white country, despite the fact that that is changing. The top circle that you see here is the ethnic population of our clinic, and this is the ethnic population of the Pacific Northwest. So the biggest chunk of that pie is Caucasian people of white ancestry. The smaller chunks are people of African ancestry, people of Asian ancestry. We're a little bit underrepresented in the Asian group, in our patient group. But essentially, even though we are overwhelmingly, my patients are overwhelmingly Caucasian, our population is also overwhelmingly Caucasian. So I don't think there's tremendous bias in that regard. Sorry, I keep clicking the wrong thing here. Hold on a second, let's do this. So I'm speaking to the converted. I don't need to tell you about Turner syndrome, but the definition really is a chromosomal disorder, which is characterized by loss of part or all of the second sex chromosome. And that's really important, particularly for non-geneticists, is to recognize that it's not loss of the X chromosome, it's loss of the second sex chromosome. So you can have loss of the Y chromosome as well as loss of the X chromosome. And really what it ends up being is actually loss of the short arm of the X. So you can have Turner syndrome if you're straightforward 45X. You can have it if you are mosaic, meaning that you have two chromosomally different cell lines. They don't necessarily have to be normal cell lines. And that's one of the problems in Turner syndrome, is when people talk about mosaicism in Turner syndrome, they're thinking about women who are mosaic for an X and two X's. So women who have a normal cell line. But there are many women who have a cell line that's 45X and 46X ring X, or 46X isochromosome X, or 46X Y deleted. And they are not normal because they don't have any normal cells. So you can have a ring chromosome. Let me get my little arrow here. Are we having problems?
No problems. I just want to zoom in on you a little bit.
Okay. So you can have Turner syndrome if you have a ring chromosome X. You can have Turner syndrome if you have an isochromosome X, which is a duplication of the long arm of the X with loss of the YP material. I'm sorry, the XP material. So this is an ideogram of the X chromosome. And the important area, the area that's really important for having Turner syndrome, is if you are missing this area of the X chromosome. So the proximal part of the short arm of the X. And this is an area in the X chromosome that contains a region which does not inactivate. So this is a pseudo-autosomal region. It contains genes that are like genes on the autosome. You all know that in females, that one of the two X chromosomes inactivates. It stops basically being transcribed once we're very early in embryogenesis. But this part of the X does not inactivate. Because you could ask the question, why do women with Turner syndrome have Turner syndrome? I mean, functionally, in each one of my cells, I'm 45X because only one of my X's is working. But not one of my X's is working. One of my X and a part of my other X is working. So Turner syndrome may occur because early in embryogenesis, you may need to have both sex chromosomes, period. But secondly, you need to have that area that does not inactivate continuing to function. So that's the important part. And if you're deleted for this, you're going to have the phenotype of Turner syndrome. So in our clinic population, this is the distribution of karyotypes that we have. About half of the patients are 45X, so they're straightforward 45X. It was hypothesized by Judy Hall that those girls with Turner syndrome with 45X that survive to be born, because a significant number of those conceptions are lost during pregnancy, must in fact be mosaic for a normal cell line, otherwise they wouldn't survive. But in the few studies that have been done looking at that, that's never been proven. Okay, so there are about half of our patients are straightforward 45X. About a sixth of our patients are mosaic for a normal cell line, and these women phenotypically can range from absolutely normal appearing females to women who have everything that you would want to have in Turner syndrome. So it's not predictable. Women who have an isochromosome X, the deletion of the short arm and duplication of the long arm, women who are mosaic for that, and for 45X. If you have a structurally abnormal X chromosome, it tends to get lost very early in embryogenesis. Thank you. So that's the derivation of the mosaicism, for example, here. We have a small number of women who are mosaic for a Y chromosome or a deleted Y chromosome, and I do not include in this in any of these data. We have 6 or 7 patients who have a male phenotype who are mosaic for 45X, 46XY, and they are not included because I was not interested in them and we didn't follow them at all. But you see the two green bars, are women who have normal X chromosomes in at least some of their cells. And then we have women who are mosaic for triple X as well as mosaic for X, double X, and triple X. And these women, again, phenotypically are a little bit different. So this, again, is just a pie chart representation of that to give you a different way of looking at that. The vast majority are straightforward 45X. So why do they come to diagnosis? So patients come to diagnosis for Turner syndrome because they have one of the cardinal features. Lymphedema, about a third of patients present with lymphedema in the newborn period. Short stature, so about a third. And these, what I'm telling you right now, is based on historical data because the times have changed and prenatal diagnosis has become the major form of diagnosis. I'll talk about that again in just a second. So a third of the patients are diagnosed because they're edematous in the newborn period, a third in childhood because they're failing to grow, another almost third because of primary amenorrhea in teenage years. And if you look at those women, most of them are also short. But their shortness has been blown off. Oh, they're short because their mother was short or they had a great-grandmother who was short. But in fact, they were short as well. Lots of other reasons for people to come to diagnosis. And then in prenatal diagnosis is becoming more important. If you look at the girls who are just 45X, you see the big difference is that edema. Because edema is much more common with straightforward 45X. And so that's a much more common reason for their presentation, for their diagnosis. But if you look at the ages, those patients in our database who are less than 25 now, okay, not at the time that we knew about it, but now, you can see that prenatal diagnosis is the major reason for them coming to diagnosis. Okay. And we have no idea, we do not have access to that data in the United States, how many conceptions now with Turner syndrome are being terminated by choice. I see a lot of those patients get referred to me, the pregnant mothers get referred to me for counseling, and then I don't necessarily know what they do afterwards. So the incidence of Turner syndrome, in fact, is probably less than it was in the past because of an increased use of prenatal diagnosis. And particularly as we move to prenatal diagnosis that is based on routine ultrasound screening for nuchal thickness and maternal serum screening, we're going to see more and more of this. So, I think the nature of the population that we're seeing is going to change. So again, the clinical features, and for most of you, you're already aware of this, lymphedema, and that puffiness is due to hypoplasia of the lymph channels. They don't develop normally, and then over time they do develop. So the babies at birth have puffy hands and puffy feet. They have nuchal thickness, they have nuchal redundancy, and you end up with that webbed neck and that W-shaped hairline. So many of the young women who come to diagnosis in mid-childhood, you don't really notice that they necessarily have a short neck, but if you turn them around and pull up their hairline, you'll see that they have the hair, and you get that arrow back here again. Sorry about that. That hair coming down on the sides of the neck. Okay. A lot of the features, physical features that we think about with Turner syndrome, they have often deep-set hypoconvex or hyperconvex nails, posteriorly rotated ears, and protruding or simple ears are all the result of the physical effects of edema in utero. Okay, so it's a mechanical thing. And there are some arguments by some people that the congenital heart disease that we see is also in part because of the effects of lymphedema. And I think there's less documentation for that. But a lot of the clinical features that you see are really the result of the edema. And usually the edema is not a big-time problem. It usually goes away over a couple of years. But you can have persistent edema, and right here with chronic edema, you can get changes of the skin and chronic problems. But that nail, that deep-set nail, that's a function of the edema. And when the babies are born, they often have these really tiny, deep-set little toenails, and they kind of grow up, and it makes it trouble wearing shoes. And you can reassure the parents that over time that does get better. So the second thing is short stature. Short stature is a cardinal feature of Turner syndrome. These are the data from our clinic. In our patients, we have 250 patients for whom we have final height. They finish growing, who have not received any growth hormone treatment or Anavar treatment. They have received estrogen treatment and ovarian hormone replacement. The mean adult height in our population is 148 centimeters and some change. The median is 147 centimeters. We have 66 women who've received growth hormone treatment, and the mean height in that group is 152 centimeters. Again, the median is 152 centimeters. So again, with treatment, and these are not matched for any features at all. These are just really separating the groups in terms of treatment. So a mean difference of about 4 centimeters in height, which is about 1 3/4 inches. Whether that's in fact worth the candle is something that I have grave concerns about. but certainly the patients are very excited and happy about this. So short stature, if you look at population studies, if you look at other studies looking at mean adult height, it ranges from 143 to 148. And if you look at the studies of the height gain with growth hormone, it ranges from 148 centimeters to 163. So this is an outlier in terms of expected adult height. So there clearly does appear to be some increment in height, but how significant that is and whether it affects the quality of life is really not known. And we'll talk about that in just a second. So it costs, at least in the United States, it costs anywhere from $33,000 to $35,000 American dollars. So multiply that by 0.82, and you'll know how many krona those are. I will say the dollar is going down and krona is going up for each centimeter of height gained. And although there have been, let me see, I don't know if I have that on my next slide. No, so let me just talk about that right now. We treat girls with Turner syndrome to make them taller, not because they're sick, not because they have a bone disease. We treat them because we think or thought being taller helps you to integrate more into society more normally. It makes life easier. It's better to be taller. Okay, it's not a health issue. It's a social issue. There have been 2 quality of life studies that looked at this, which are very, very small, and they show no difference in quality of life. We've done a study looking at quality of life in women who've been treated and women who haven't been treated and have not published it because some of the data are not interpretable, but we don't see any difference in sense of satisfaction, depression scores, integration into society, etc. So it's not at all clear that even if this height gain is real, that it has a significant impact. That doesn't mean to say, and I'll talk about this again a little bit later, that doesn't mean to say it's not important, because if you think you've taken control over something in your life, I was genetically programmed to be short. I have this condition or this disorder or this disease that, we can do nothing about, and now we can do something about it. Whether what you do makes a difference physically or for your health may not be as important as the idea that you've taken control of it and you've done something. So I can't speak to that. I think that may be an argument for treatment, but I don't know the answer. And again, I'll talk about that a little bit. The third major feature is gonadal dysgenesis, and this is for you. You can see these little streak gonads that are standing there at the end of the tubes, and that's the third major portion of Turner syndrome. Now, the gonads are actually formed in embryogenesis, but they are, if they are ovarian in origin, there are many fewer follicles, and they don't survive. So it's as if the girl with Turner syndrome goes through menopause before she even gets born. And that's how I present it to my patients. And somehow that, for some people, and particularly for some mothers, is a little bit more comforting than the idea that my daughter didn't have ovaries at all. That yes, you had them, but they just didn't survive. And that, there may still be some residual ovarian function. So if you look at spontaneous development of puberty and spontaneous menses in girls and women with Turner syndrome, among all of them, about 25% of patients will have spontaneous bleeding. Most of them will bleed once or twice and then have secondary amenorrhea. This is, in terms of our group, 75% of the women needed to have hormones to go through puberty, but 25% had spontaneous puberty. But when you look at karyotypes, those that are 45X, 9% of those patients had spontaneous menses, and 91% needed to have hormonal help. And of the 9%, almost all of them went into secondary ovarian failure fairly early on. If you look at those women who have a normal XX cell line in addition to their 45X line or a triple X line, 61% of them have spontaneous puberty and spontaneous menses. We see a small but significant proportion of women with 45X, 46XX, and 45X, 46XX, 47XXX, or 45X, 47XXX, who get referred for premature ovarian failure in their late 20s, early 30s, or for recurrent pregnancy loss. So beginning to see more women in being referred for diagnosis in that group because they have a high rate of either infertility or pregnancy loss. There have been very few really long-term longitudinal studies. Close to home for you is Klaus Gravholt in Denmark, and he has access really as a captive population in Denmark because they have a registry of about 630 patients, of which about 300 to 350 are adults. And he's been following now, collecting data for about 7 years, and he is planning to try to do a multi-clinic, multi-center study, which hopefully we'll be part of, to really try to answer many of the questions that I'm going to be posing. Gerald Conway in England has had a clinic for about 15 years that has about 500 patients. In the Netherlands, there's a clinic, a population of children and adults of about 150. The NIH has a clinic, or had a clinic, that has about 226 individuals, many of whom come from our clinic. But that is now closed. And in Seattle, we have, as I said, about 660 patients, and it's been going on for 40 years. So we really don't have a lot of data. Everything that we're saying is really based on very limited data. So what I'm going to do in the next series of slides is really present facets of medical care and try to present two different sides of it. One is, what do we know now and what's important for care? And then what don't we know, and what would a natural history study help us to answer? So really the difference between what we knowledge and what we'd like to know, we need to know. Okay, so these are the issues that I'm going to run through very quickly. Lymphedema, short stature, gonadal dysgenesis, cardiac aspects, renal aspects, bone aspects, ear aspects, thyroid disease, GI disease, diabetes, and psychosocial aspects. And the psychosocial aspects are really incredibly interesting, probably the hardest to quantify and to sort out. It's the kind of thing where in my clinic staff can recognize a patient with Turner syndrome when they answer the phone. Part of it's because of the actual sound of the voice, because there are changes in the way the face develops. So there's a slightly high-pitched nasal quality to the voice in many of the women, but also because of their organizational conversation and how they organize it and trying to get information from them. So there are cognitive issues, and it's never politically correct to talk about cognitive issues, but they're there, they're real. Not everybody has them, but they're really hard to quantify and fascinating. What does the X chromosome do to the brain, and how does that happen? So these are all issues that we really need to know more about. So in terms of lymphedema, it's usually not an issue in adult life. As I said, the lymphedema usually resolves and it goes away. It's the management of lymphedema is not Turner specific, and the management of most of the problems in Turner syndrome is not Turner specific. If you have diabetes, it gets managed as diabetes. It doesn't get managed as diabetes in Turner syndrome. If you have a bicuspid aortic valve, it's a bicuspid aortic valve. It doesn't matter that you have Turner syndrome. So the management is usually not specific to the condition. The lymphedema is a ripe area for research. What are the downstream consequences, as I said, of having lymphedema are some of these physical changes. Why does it get better as people get older? Why do the lymphatics start to work? Occasionally, lymphedema will recur at puberty or recur in adult life, but that's fairly unusual. And is it a paradigm for understanding embryologic development that's phenomenologic? So not based on genes, but actually based on what's happening physically in the embryo that directs what happens in terms of organogenesis. Then the short stature, there are really functional issues. There are no treatment issues in terms of short stature for adult women once adult height is reached. You're not going to be treating their short stature unless they want to wear heels. The concerns that I have is that we do not know what the long-term consequences of growth hormone are. So again, the benefits of treatment with growth hormone, do you get taller? Probably. Is being taller better for you? Unclear. And are there long-term consequences? Because growth hormone changes things. It changes the way the bones develop and grow. So you can argue that it allows the bones to be stronger, and therefore maybe the women are less likely to have fractures. It's not clear that fractures are an issue, so we'll talk about that a little bit. It changes the shape of the bones. So if you look at the girls who are treated, their hands tend to be bigger, their feet tend to be bigger. It changes the configuration a little bit. There's an increased risk, for example, of slipped capital femoral epiphysis, which is a function of rapid growth. But growth hormone has an effect on other parts of the body. Growth hormone was used in elderly men to try to reinvigorate them, and there were an increased number of problems with cardiac problems. Does growth hormone treatment, it increases stroke volume? Does it increase the likelihood of aortic dissection in the future in women with Turner syndrome? We don't know. And there's no effort to capture that information. So the girls are being treated, and nobody is saying, you're being treated. And most of the girls who were treated until recently were treated as part of studies. So they were already research subjects, and there's no effort to say, okay, we're going to contact you every 10 years and see whether there are long-term, is that group more likely to develop diabetes, or less likely to develop diabetes? Are there good consequences of long-term consequences of treatment, or bad. We don't know that, and we're missing the opportunity to follow that. So I'm very concerned that we give somebody injections for 5 or 6 years of a substance we don't know what the long-term consequences are going to be. They're not growth hormone deficient. We're giving them more than they need. And I don't want to hang crepe. I'm not trying to say that this is bad, but we don't know. And I think it's really incumbent on us to make every effort to try to know, because we don't want to do any harm. Okay. So that's I think a really big issue in terms of care. But in terms of research, we don't really know why women with Turner syndrome are short. There's a gene in the on the X chromosome called SHOX, which is probably primarily important in terms of stature, but it's not the only reason. So what else is on the X chromosome that controls growth and controls skeletal development? So those are areas for research. What about the eye? There is really no organ that's not affected in Turner syndrome, but some of them are affected to a lesser or greater degree. There clearly are more problems with the eyes. Strabismus and esotropia and amblyopia are much more common. So usually as a pediatrician, if you see a baby whose eyes cross intermittently before the age of 6 months, you don't worry about it very much. And a girl with Turner syndrome might be more likely to pay more attention to that because it's more likely to persist. There probably is a slightly increased occurrence of early onset cataracts. Again, we don't have good numbers for that. But what do we do? Should we be screening these women? Should we be, offering them earlier eye examinations in adult life? We really don't know the answer to that. And then why isn't the eye more involved? Why is the eye, actually minimally affected? And why do they have strabismus? And is strabismus possibly related to the fact that they have ptosis? They have these droopy eyelids, which is because they have edema. And so the globes are not normally, one globe is depressed, or they're not lined up. I mean, we honestly don't know the answer to any of those. So if you're an ophthalmologist and you want to study something, Turner syndrome is a great place for you to go. And if you look at on all of these slides, there'll be a graph at the bottom which shows really, the yes or no. So almost half of our patients have some problems with their eyes, but for many of this also includes myopia, just includes nearsightedness. So it's probably not as significant as this. Well, ear, nose, and throat. This is a huge issue in Turner syndrome. And I've actually had a father say to me when he was concerned about recurrence risk for Turner syndrome, that if he was going to have another baby who had recurrent ear infections, he would abort, because the ear infections that these kids have, and about 75% of babies and girls with Turner syndrome will have recurrent ear infections. They'll have 6 to 8 to 10 ear infections a year, which means every Saturday night at midnight the baby starts to cry, and then you have to go to the emergency room, and it's really a life-altering problem. But chronic ear infections and then sequelae secondary to that. So conductive hearing loss, cholesteatoma, which are the tumors that grow in the ear canal. Chronic problems with conductive hearing loss are really an issue. Sinusitis in adult women is very common. And this is really all a function of the mechanics of the way the face develops, because the face is hypoplastic in Turner syndrome. The eustachian tubes that go from the nose to the ear are smaller. They don't function normally, so they're much more likely to close off when you get a cold. Then you get fluid in the middle ear, and then you get your secondary infections there. As they get older, the face does tend to develop more. The sinuses do tend to develop more, so the problems become less. But a significant number of the women have continuing problems with recurrent sinusitis. The second thing that happens in Turner syndrome is that they are at increased risk to develop sensory neural hearing loss, which is fairly evocative of presbyacusis, in that they lose high-frequency hearing and have problems in understanding speech. For many of these women, it's really, really important to recognize, because they already have problems in decoding speech and in processing. And if they're not hearing normally, it makes it even worse for them. So you really want to try to stay on top of that for them. And then, like everybody with hearing loss, they don't like their hearing aids. They don't want to wear their hearing aids, and they don't have them that much. So, the management of the problem is really no different than it is for anybody else. But what are all the mechanisms of hearing loss? What genes on the X chromosome are related to sensory neural hearing loss? There's no information about this at all. So again, a really ripe area for research. The thyroid. This is incredibly interesting. Thyroid disease itself is not uncommon. The NIH did a survey, and about 4% of the adult American population will have hypothyroidism. So it's a very common problem. There's the Framingham study, which is a study that is based in Massachusetts. About 6% of women with normal women will develop hypothyroidism if they're older than 60, and about 2.5% of men. But about 30% of women with Turner syndrome will develop hypothyroidism. So it's much, much more common. Luckily, it's relatively easily treated, and they also develop it earlier. So we do see a development of hypothyroidism in sort of mid-late childhood. I don't start screening until they're older than 10 for hypothyroidism, but other people may start screening earlier. So if you look at the patients who are less than 18, you can see a small proportion are hypothyroid. But if you look at the patients over 18, about a third develop hypothyroidism. So again, that's the age group in which you have greater concern. So thyroid screening is clearly needed. It's not Turner specific, but again, the frequency in Turner syndrome is higher, so you need to do it and think about it more. And a yearly TSH is, I think, enough. And again, some people will look at thyroid antibodies first because you develop antibodies to the thyroid first. We don't do that because you don't treat antibodies. You don't treat until you see an elevated TSH. So from a research standpoint, it may be interesting to look at that. From a clinical standpoint for patients, we just follow TSH, and we do treat before thyroid functions become abnormal. Are there genes on the X chromosome that are responsible for autoimmunity, and that's why thyroiditis and hypothyroidism is more common? Acute Hashimoto's thyroiditis is a little bit increased, primarily in those women who have an isochromosome X. But thyroid disease is increased among all and across all karyotype groups. So, what is causing that? What's the reason for that? What determinants make hypothyroidism a problem in these women? We really don't know. I found this study, which was really interesting to me and really gave me food for thought in terms of thyroid disease. And this was a study out of Finland. And they looked at women who had hypothyroidism and 293 women with spontaneous hypothyroidism. And what they found was that on average, this is a truck in our parking lot, so I'm sorry if you can't hear me. But they found that on average, these women were had lower birth weight and were shorter at birth, and that they were smaller in childhood, and they had lower body mass index in childhood. And their conclusions were small body size at birth and during childhood increases the risk of spontaneous hypothyroidism. Let me stop for a second. I'm going to stop, take a drink. Didn't he get the notice that I was here? Okay. Well, I thought this was a fascinating study because maybe it's not having Turner syndrome. Maybe it's being small. They're small at birth. Their birth weight is lower, and their birth length, their mean birth length is 18 inches, which is I can't do the quick centimeter conversion there. But their mean birth length is at the 3rd percentile. So maybe it's a function of these factors and not the X chromosome itself. So I haven't seen anything subsequent about that or whether that's been followed up, but I thought that was really fascinating and kind of reminds you to take your head out of your specialty oven. That we know it may not be the X chromosome that's doing all this. It may be something consequent to the X chromosome, which is then doing that. Okay, well, what about cardiac issues? And this is really a huge issue because of the concern for aortic dissection. I'll talk about that a little bit. So congenital heart malformations are certainly an issue in Turner syndrome, and any point that a girl with Turner syndrome comes to diagnosis, she should have a cardiac evaluation. That's absolutely without any question at all. Hypertension is also increased in adult women, and whether that is a separate issue from obesity and from increased body mass is not clear, but certainly a problem. And then hyperlipidemia is a question. If you look in the literature, there are multiple case reports of individuals with Turner syndrome with hyperlipidemia, and if you look carefully where a family history has been given, almost all of them have a positive family history. And that's the other thing that we fail to do. So you look at a clinic population of women with Turner syndrome and you check their lipids and you go, oh, look at that. 20% of them have hyperlipidemia, and don't take a family history, and it turns out that, oh my goodness, their families have it as well. So you always need to look at things in the context of they don't just have Turner syndrome, they have everything else that's in their family as well. And then dissection of the aorta, and whether that's an increased Turner-specific risk, who is at risk, and what to do about that. So in terms of cardiac involvement, half of our patients have cardiac involvement. It's, again, very, very common in Turner syndrome. If you look at the difference between the 45X patients and patients who don't have a 45X cell line, they're really, I did not do significance on this, so I don't know if the difference between 59% and 43% is significant with these numbers. It probably is, but we have to sort that out also for the ages of the patient. So having a 45X cell line probably does increase the likelihood that you're going to have cardiac abnormalities or cardiac malformations. So what about aortic dissection? This is a problem that's become more apparent in the last 15 or 20 years. There were initially a few patients that reported in the literature, and that raised concern. And so in our patients, with all of our patients, we have 8 patients who've had a dissection of the aorta at a variety of ages, and all of them have predisposing risk factors, and I'll talk about that specifically in just a second. There have been more than 90 now. There have been about 105, but I didn't update the slide. Patients in the literature who've had aortic dissection. These are some series and also case reports. All except 5 of them had predisposing risk factors. So something that if you have it and you don't have Turner syndrome increases your risk for aortic dissection. For example, a bicuspid aortic valve. Angela Lin did a study and from a self-reported survey of patients with Turner syndrome. She had 15 patients who had a dilatation or dissection of the aorta, and 12 of those 15 had predisposing risk factors. And again, of another series, 1% of the patients had dissection. The NIH study, they had 3 out of 166 patients who had dissection of the aorta, and 2 of those 3 patients had predisposing risk factors. Carlson and Silberback published in 2007 and in 2009 the same 2 patients and the same survey of the literature in 2 different publications, and they reviewed 90% of patients in the literature had predisposing risk factors, and they have a voluntary registry now of patients. 20 patients in their registry have had aortic dissection, 19 have had predisposing risk factors. So I think that that's a really important thing to remember. We'll talk about that a little bit more in the next slide. So in girls and women with Turner syndrome, the most common malformation is bicuspid aortic valve, and it is also common in the general population. So anywhere from 0.5% to 1.5% of people in the general population will have bicuspid aortic valve. In Turner syndrome, it's upwards of about 20%. And if you look at individuals who have bicuspid aortic valve, it is associated with a high risk for dilatation of the aorta, for widening of the aorta, and that predisposes to risk for dissection. So if you have bicuspid aortic valve in the general population, it carries a lifetime about 6% risk of aortic dissection, 9-fold higher than in the general population. So that itself is a predisposing risk factor. You look at the incidence of aortic dissection is estimated to be about 5 to 30 cases per million. So when you see a range of 5 to 30 per million, you realize nobody really knows, and that there are about 2,000 new cases a year of aortic dissection. The true frequency of, these are all from the literature, the true frequency of aortic dissection is difficult to estimate, and most estimates are based on autopsy studies. If you look at autopsy studies, aortic dissection is found in 1 in 128 to 1 in 745, or between 0.1 and 0.7% of all autopsies. And the risk of aortic dissection, this is from a paper, 2 papers that have been published, the risk of aortic dissection in Turner syndrome may be as high as 0.6 to 1.4% compared to a risk of 0.0006 in the general population. But this is very similar to the risk of having aortic dissection with a bicuspid aortic valve. Okay, so it's not very different. And Conway, in a paper in 2010, said it's estimated between 1 in 17 and 1 in 40 women with Turner syndrome will die of aortic dissection. But how do we get from 0.6 to 0.2% to 2.5 to 5.8%? So he's a very good doctor. He's a very good investigator, and he writes really beautiful papers. But I think that there's been a lot of crying fire in a place where there isn't a fire, and a lot of concern raised for patients. And for my patients, particularly my adult patients, they come in, and this is the thing that just scares them. They're afraid to go to sleep at night because they think their heart is going to explode, and they're going to die of aortic dissection. And really, that's not true. So how do you present these data to your patients? Because they're going to be asking you about it. They're going to be Googling. They're going to be Wikipediaing. They're going to be reading the literature. They're going to be seeing other physicians who haven't read the literature but saw something that said that aortic dissection is a risk. And I think that there are different ways to present things. You can say your risk to have an aortic dissection is 100 to 200 times higher than the general population. That would scare me. Okay. All right. And these are maximum risks. But you can say there's a 98 out of 100% chance you're not going to have an aortic dissection. And that's saying the maximum risk. That's, there's like, that's not so bad. I can live with that. So the way that you present the data, you can present it in an alarmist fashion. You can present it in a reassuring fashion. I think the way you want to present it is the way that the patient takes good care of themselves. So you can encourage people to not try to manage their weight, to try to eat well, to try to exercise, to make sure that they get their MRIs, or sure that they get their cardiac echoes, or make sure that they go and see their cardiologist, that they do get their blood pressure checked, that they have high blood pressure, that they treat their blood pressure. I mean, you want to impress upon them the importance of this, but you also want them to be able to get up and live their lives and not feel like there's a sword hanging over their head that's just going to drop on their heads and kill them. And I'm very concerned that we over-medicalize our patients. It's one of my concerns about growth hormone. And I've had patients say to me, you keep telling me I'm okay and there's nothing wrong with me, you keep trying to change me. And girls who say, I'm taking shots 6 days a week. I mean, I feel like I feel like I'm sick. And other girls who go, I'll do anything to be taller. I mean, so patients will approach things differently. But we over-medicalize because as physicians, we don't want to miss something. I mean, I don't want to be responsible for missing an aortic dilatation in a patient. And so I'll say, well, get screened every year so we don't miss it. And then I make them sick. And I interfere with the quality of their life. So that's a very fine line to walk. I have answers for me and how I want to deal with it. I don't have answers for you and how you should deal with it. So in terms of what do I think in terms of cardiac management, all individuals with Turner syndrome need a baseline echo. And right now, there's some transition as to whether you need to do MRI or MRA, because for some of them, echoes are technically difficult because of the way their bodies are constructed. It's not the gold standard yet. It's far more expensive and harder to do, more frightening to the patient. So currently, echoes are still the way to go. They all need to get their blood pressure checked every year, and it's reasonable to evaluate lipids, mostly because if they do have hyperlipidemia, you want to treat that, but not necessarily because of their chromosome abnormality. But what we don't know, what we want to know is what are the genetic controls for left heart development? What's going on in the X chromosome that affects the way the left heart? Because if the abnormalities in Turner syndrome are primarily left heart, a significant proportion of babies with Turner syndrome, not a significant proportion, but babies with Turner syndrome are born with hypoplastic left heart. Hypoplastic left heart is a much more common heart malformation in boys than it is in girls. So if you have a girl baby with hypoplastic left heart, karyotyper. Think about Turner syndrome. The risk for aortic dissection in the absence of high blood pressure, coarctation, and bicuspid aortic valve is uncertain, and the likelihood with risk factors is still uncertain. The need for and the frequency for repeat echoes in adults with risk factors is uncertain and may not be different from that for people who have bicuspid aortic valve and don't have Turner syndrome. The need for frequency of repeat echoes in adults without risk factors is uncertain. And I've been part of the groups that have made recommendations, and they went from every year by the American Academy of Pediatrics, and the cardiologist went batshit and said this is crazy, to every 3 to 5 years, to every 5 to 10 years. And these numbers are really based not on data, but on best guessing. What's the risk for adverse events secondary to hyperlipidemia? And does growth hormone affect the risk for dilatation and dissection? We don't know the answer for that. And I think that Gerald Conway really said it best, that the optimal time for repeat aortic measurements is not yet defined. MRI scanning is more sensitive than echo, but whether it's of practical benefit in altering management is unclear. So we still don't know, and we're still trying to learn about that. The kidney is affected in Turner syndrome. The horseshoe kidney or duplication of the collecting system is fairly common. About a third of patients will have renal malformations, but they just need a one-time renal ultrasound. The risk of this is, number one, you want to know if you only have one big kidney, because if you're in an automobile accident, you don't want them to take out your one kidney. The surgeon needs to know you don't have one on the other side. And then the second thing is that some of the girls can have quiet reflux and get hydronephrosis, because if they have duplication of the collecting system, sometimes the ureters will occlude each other. So a one-time renal ultrasound is really mandatory. But following them after that, unless they have something structural that can cause some problems, there's no reason to do that. And in an adult woman with Turner syndrome, I want a renal ultrasound because, again, I want to make sure she doesn't have a horseshoe kidney, and secondly, because I need it for my data. So there's that. And then again, what's going on? It's been argued that what happens is if the kidneys develop, they come down and develops as one on-login, which then separates. So the kidneys separate. And so what you have with the horseshoe kidneys, you have failure separation. And the embryologists argue that the reason you get failure separation is because you have edema that prevents that separation. That makes no sense to me at all, phenomenologically, but that's one of the arguments. And so are the renal malformations a function of what the genes are on the X chromosome, or are they a function of something that's happening mechanically during embryogenesis? And we don't know the answer to that. What about their bones? This is an area of great controversy and limited information. We know that Turner syndrome is a skeletal dysplasia. It's not just short stature, that there are abnormalities in the way that the bones have developed. One of the congenital dislocation of the hip is certainly increased in frequency, so all of these babies need to be checked for that. And problems with patellar instability, they have small patellae, and knee problems are very common in adult women. The question about osteoporosis in Turner syndrome has not yet been answered. If you do DEXA scans in young children with Turner syndrome throughout all age groups in Turner syndrome, their bones will appear to be osteopenic. They have a skeletal dysplasia. Their bones do not normally mineralize in a way that can be interpreted by the DEXA. But whether they actually have weak bones or bones that fracture, if they have truly an increased risk for osteoporosis, is far less clear. We don't see a big decrement in bone mass over time necessarily, so that you can get a DEXA scan at age 15 that shows osteopenia, and it's going to show the same osteopenia at age 30. And it may be because, again, the bones themselves are not normal. So that what we interpret as osteopenia, in fact, is not. There's been a lot of question about whether there is an increased risk for fractures. One study at the NIH that was looking at growth hormone and estrogen treatment by Judy Ross and Penelope Fullion reported an increased risk of fractures in their patients. They actually had 2 wrist fractures in young girls, and I question whether that's because their bones are weak or because they're clumsy. And that's really an issue. These girls are not physically adept for many of them, and they're more likely to, they're going to be higher on the monkey bars than somebody else, and they're going to fall from a higher height or be small, whatever. So, is the increased fracture risk not because of the bones themselves, but actually because of the activities that they're engaged in? What's the role of ovarian hormone replacement in managing the bones? What's the role of growth hormone? Do we get more bone mass with growth hormone that they need to have to prevent osteoporosis in adult life? And what the heck is it with the fourth metacarpal? So one of the signs of Turner syndrome is that you have a short fourth metacarpal. So you get knuckle, knuckle, dimple, knuckle. Okay. But the short fourth metacarpal is the most commonly short bone in humans. So if you took everybody in this room, you might find somebody who has a short fourth metacarpal. So what is it about it, and why is it affected? We really don't know the answer to that. I want to go back to the bones for just a second. In terms of fracturing. That's a real issue. What we don't know is when to stop HRT in women and adult women with Turner syndrome. Should they take estrogen throughout their entire lives to help maintain their bone mass, or do we put them at more cardiac risk? And most people who take care of adult women with Turner syndrome now in large groups are tending to stop them in their 50s and their 60s if they want to stop. If they don't want to stop, we go, okay, you can continue. But we really don't know how long to treat them. Gastrointestinal issues. There are some gastrointestinal issues in Turner syndrome. The question of, how do you monitor for diabetes? What's the risk for diabetes? Obesity. Obesity is a real problem for these women. Some of it is probably endogenous, but most of it is cultural. If you have a Big Mac attack and you are 4 foot 8 inches tall, you are going to get all the calories you need for the day in that Big Mac, getting your Mac and your French fries. So if you eat a typical American diet and you have Turner syndrome, you're going to become obese. There's no question about that. So you really have to monitor that. And the question of celiac disease. And I don't know what's happening in Norway, but celiac disease in the United States is kind of flavor of the week. So everybody is coming in and telling me that they have celiac disease. And I'm a dermatologist, and there's a disease called dermatitis herpetiformis that's associated with celiac disease. Celiac disease is really not common, But people are coming in and going, I can't eat bread. It's really causing me this problem. So, but the question was raised, is it more common in Turner syndrome? And if you look at antibodies, they are increased. So probably in the few small series that have been done, about 25% of patients with Turner syndrome will have thymosyl, I can't pronounce it, antibodies. But frank celiac disease does not appear to be clearly increased. So how do you monitor for that, and when do you monitor, and how often do you do that? So is diabetes actually increased above and beyond the expectation for their body mass index? Is it more than you would expect just because of their weight? And does the type of ovarian hormone replacement that they get make a difference, and there's some arguments there. What's the risk for liver disease? Fatty liver is a problem in these patients. And is there a relationship to ovarian hormone replacement? And what about the gallbladder? Because gallbladder disease is also increased in these patients. They have a higher rate of cholecystectomy. And is that separate from the fat, fair, and 40, which are the risk factors, and fertile, which are the risk factors for gallbladder disease? Again, is it weight related rather than chromosomally related? So I'm just going to run through this. Celiac disease affects 1% of healthy average Americans. I don't really think so. This is a study that was done out of Chicago. And in average healthy people, they found celiac antibodies in 1 in 133 patients. And in patients who had symptoms that suggested celiac disease, of course, about 1 1/3, so much more common. So in the discussion in the article, they said it affects 1% of healthy average Americans. But if you look at the numbers, it's actually 0.7%, and it's not disease, it's antibodies. And so the prevalence is reported in patients with Turner syndrome have been 3 in 150, 2 in 56, and 13 of 256. So we really don't know. This is, again, based on serologic screening, not based on intestinal biopsies. So what do we do with our patients? And as far as I'm concerned, let them eat cake. I don't think we should be getting these patients really worried about it. I think it's probably reasonable to screen for antibodies because, again, we don't know enough, so let's get that data. But I don't think that we need to be telling our patients that they have celiac disease if they don't, or they have celiac sensitivity. And I don't truly know if it's an aspect of Turner syndrome, specifically whether it's an aspect of autoimmunity being increased, just autoantibodies, or whether it's just part of, now everybody has celiac disease and that's going to quiet down in the next couple of years. I don't know the answer to that, and I'd be interested in kind of your views. So diabetes, again, is a big problem, an epidemic in America, again, associated with our epidemic of obesity. These are data from the literature about the occurrence of diabetes, 8.3% of the U.S. population. It's a big problem. When we look at patients with Turner syndrome, in one study in 2009, type 2 diabetes was present in 25% of their adult patients. They had type 1 diabetes in only one patient. In our experience of our 557 patients, we have, on whom we have data, so the numbers are not the whole group. We have 13 or 2% who have type 2 diabetes, 5 of whom have a positive family history of type 2 diabetes. So again, everything has to be in the context of the family, not just the individual. And I don't know that people have looked at family histories for any of these other studies. And we have 2 patients with type 1 diabetes. We know that there are risk factors for these patients to develop diabetes, and those risk factors, of course, are their body mass index. Gonadal dysgenesis. When do we initiate hormone replacement, and how do you initiate it, and how do you do that? And there are lots of different ways to do that, and there are lots of different arguments about how to do that. Sexual function and dysfunction is an area that there's not very much research in at all. These women tend to have drier vaginas. They may have small vaginas. There may be a lot of dyspareunia, and it's kind of a no-go area. And I think it is an area that we do need to go to and need to deal with this because these women will suffer in silence, and they do. So what do we need to know? What kind of hormone therapy? Is Premarin and conjugated estrogens really bad, or actually people use them for years without any problems? Do we use patches? Do we start slowly? These are all things we don't have answers to. What about assisted fertility and the risk for complications? There's been concern raised about an increased risk for aortic dissection with assisted fertility. I'll talk about that in just a second. Spontaneous fertility, there are issues with risk for aneuploidy. Retrieval and storage of ova. This is something that's really happened in the last 5 or so years, that it's now technically possible to save ovarian tissue and to retrieve and freeze eggs, which was not possible earlier. So particularly for those patients who are mosaic for a normal cell line, the potential to have some ovarian function, this is a discussion that has to start happening in early teenage years. We used to tell our patients who went into spontaneous puberty, if you want to become pregnant, don't defer that for your career, because you are at a higher risk for premature ovarian failure. But now we really have to say you might want to think about harvesting your eggs, recognizing that your eggs have a higher risk of abnormal chromosomes. So that's a discussion that's just beginning now because of the technology, and I don't have a firm way of doing that. And what about gynecologic malignancy? What is the risk there? So this is a survey. This is basically looking at the literature. And this is from a paper that I published some time ago where I went and looked at all the reports. If you look at the number of pregnancies in women, there are pregnancies in women who are 45X, women who are mosaic for a normal cell line, and other chromosomal variations. The risk for spontaneous pregnancy loss is quite high. So their risk of pregnancy loss is, upwards of 30 to 40%. Stillbirth is also increased. Trisomy 21 is also increased. So why they have a risk for trisomy 21 is unclear mechanically, but that's a higher risk in their live-born children. X chromosome aneuploidy is also increased. That also doesn't make any sense because they have an increased risk for mosaicism. So why, if you have an egg, why would you might have an increased risk, might be an X empty egg, so you might be at increased risk for Turner syndrome in your offspring, but why mosaicism for Turner syndrome? It doesn't make any sense. In terms of congenital malformations, there's no increased risk. The risk for congenital malformations parallels that of the general population. So there's an increased risk of pregnancy loss, failure to carry pregnancy to term, an increased risk of chromosomal aneuploidy, but there's no increased risk of other abnormal outcomes. So about a 1 1/3 risk in terms of literature, or likelihood, risk or likelihood, depends on your bias, of having a normal live-born pregnancy, and in our population, about half of the patients. Okay. So there is concern that's been raised about pregnancy and assisted pregnancy in patients with Turner syndrome because there were 2 patients that were reported who had gotten gamete interfallopian transfer and developed aortic dissection during pregnancy. One patient developed dissection during a spontaneous pregnancy, and one patient had it developed it 2 weeks after pregnancy. So this raised a huge hue and cry, at least in the United States. I don't know about other places, that we should not do this in women with Turner syndrome. We should not do assisted fertility in these women because we were basically signing a death sentence for them, which is incredibly paternalistic, because that's a decision that an individual woman should be able to make for herself, knowing what the issues are. So there was some pushback from those recommendations that gift not be considered at all, back to, well, wait a minute, let's look at that data a little bit more carefully and let's look at this a little bit more reasonably. One patient who was reported had a dissection while she was waiting to participate in gift. I don't think that's causal, but she was included in one of the abnormal outcomes. In a survey of assisted reproductive facilities in the United States, which was a self-reporting survey, 101 pregnancies were reported. None had experienced aortic dissection. In France, they did a survey of 93 pregnancies. 2 experienced dissection. In Sweden, 57. One patient had a dissection in her second pregnancy, and she survived that dissection. At the NIH, they had 10 pregnant women, and none, which is in small numbers, and none dissected. So who decides who gets to take a chance? I think that an adult woman with Turner syndrome who wants to become pregnant, and I counsel all of my mothers, my children, my teenagers, and my adults, when they say, I can't have children, you never let them say that. You can have children. You can't become pregnant with your own egg. That's the likelihood. The really likelihood is that you can't become pregnant with your own egg. If you want to become pregnant, there are ways that we can help you to become pregnant. If you don't want to become pregnant, and a lot of my adult patients were thrilled with the idea that they could become pregnant if they wanted to, but thought that the idea of actually doing it was, no, thank you. But the idea that they could made them feel that they were them like every other woman. They had all those options. So it's not that you can't become pregnant, it's that you're not going to become pregnant with your own egg. And it's not that you can't be a mother. 1 in 6 couples in the United States is involuntarily infertile. You can become a mother by adopting, by fostering, by having stepchildren. Lots of ways to do that. And we all know what they really mean. And we all know, yeah, you're right, you can't have children. But that's not really what it is. So I think it's really important to, you can change people's thinking by changing the wording that you use. We don't say you have a disease. We say you have a disorder or a condition, right? Because we change the way we think about it when we change the way we talk about it. And I think for adult women, it's not for me to tell them this is a risk you shouldn't take. I think it's, every time we get pregnant, we know, women who are pregnant die from things that women who are not pregnant don't die from. It's a risk that we choose to take as long as we know what those risks are. So I am not dogmatic about telling them what to do. I'm dogmatic about what you tell them. Motherhood, it's available. So these are adopted, live-born, fostered, and then adopted. Okay, lots of ways to be a mother. Psychosocial issues, and these are huge in Turner syndrome. They're huge because in many ways they're ineffable. They're hard to quantify. They're hard to put your finger on. They're hard to assess. And they're hard to manage and to deal with. So achievement of independence. These are girls that tend to be infantilized. They get infantilized by society because they're small. They get infantilized by their parents because their parents are scared and worried. And they get infantilized by themselves because it's ever so much easier to have somebody do something for you than it is to do it for yourself. But they may also be slower to mature endogenously. It may have something to do with how your brain is bathed with hormones, and it has nothing to do with actually how you're approached or how you're raised. And one of my all-time favorite patients is this young woman. She was 29 when she came to diagnosis, and she and her mother came to clinic. And she was, you can see she went into puberty on her own. She never received any secondary sex hormones. She had normal menses. She had normal stature. She came in and she said, I have Turner syndrome. My mother and I were reading an article about this, the cognitive issues, and I have them all. I know I have Turner syndrome. And I'm going, okay. So we karyotyped her, and she was 46X isochromosome X. She had Turner syndrome. So, this was a self-diagnosis, and it was great. And she had all the cognitive issues, and it was just amazing. And it had nothing to do with hormones, right? It had nothing to do with stature. It had something to do with that chromosome. How do you integrate these women in? So they're younger to leave home. And again, we did a study looking at that. And if we did that study today, we wouldn't find any difference because most of the young people in their 20s and 30s are coming home to stay with their parents now because of the economic situation. But in the 70s, it was not that way. So they go to college later. They take longer to go through college. They often are younger, older when they leave home. They're older to marry. They're often integrated into the workforce at work levels lower than what they're trained for. So they're very good students because they're quite diligent about things, and will get degrees and get BAs and get master's degrees, and then be working serving food in the cafeteria. Again, 20 years ago when we did that research, that was really telling. Today, I don't know about your children. My kids have graduate degrees and they're slinging hash. The barista at Starbucks is, has a master's in poetry. So things may be changing, but certainly we see that with Turner syndrome. They get there, they just get there later. What about relationships? They tend to be involved in fewer heterosexual relationships. They tend to date later than the normal general population. How does the gene dosage affect cognition? Is there a difference if you are an isochromosome X versus deletion of the short arm? We don't know. And again, I talked about this earlier. Does absolute stature or belief that stature has been affected affect the quality of life? So, if you've taken charge of something, does it affect how you think about yourself, or how if you feel like you're more normal, do you feel more normal? An aspect of Turner syndrome that to me as a dermatologist should be fascinating is incredibly boring, but they have an increased number of benign nevi. They don't have an increased risk of melanoma in these nevi, but they have more moles. Why would you have more moles with an X chromosome? I have no idea, but somebody must be interested in looking at this. Okay. Well, what about death? And that's certainly a biggie. There have been two studies, both from Europe, looking at death, and one of my pet peeves is when the newspaper says morbidity increased. It's like morbidity is not increased. Morbidity is always 100%. Or mortality. Mortality is increased if you have this. It's like, no, mortality is not increased. Mortality is 100%. We're all going to die. But it's a question of earlier mortality in these women. So he's back because it was so much fun the first time. Is earlier onset of death, is life expectancy reduced in Turner syndrome? And it certainly is. But why it is not quite so clear. If you look at our 634 patients in whom we know whether they're alive or they're not alive today, we've had 41 deaths. 13 of those have occurred in children less than the age of 18. And I'll show you those details in just a minute. And 27 in women over the age of 18. And most of them are cardiac deaths. And the same is true of what's been reported in the other surveys. So in our 13 children who died, you can see that 4 of those in red are due to heart problems, to congenital heart abnormalities. 2 of these children had different renal agenesis is really not part of Turner syndrome, so I can't say that that's because of her chromosome diagnosis. OI is not part of it. We have a patient who has achondroplasia and Turner syndrome, so you can have other things besides having Turner syndrome. We had 2 patients who died of SIDS, but they were actually cognitively quite impaired, so I'm not sure SIDS is really appropriate. That's sudden infant death syndrome. We had a sudden infant death. Sorry. And one patient who died of apnea who was cognitively significantly impaired. One had a familial neuromuscular disease from which she died, and one who was also cognitively impaired, had an additional chromosome abnormality in addition to a Turner syndrome, and she died of aspiration. So clearly the heart is a biggie in infants. In our grown-ups, if you look at the red color, for those of you who are colorblind, 8% of our males in the audience, I'm sorry. If you look at the red, these are accidents. So how can accidents be part of Turner, related to the Turner syndrome? Well, actually, it could be. The river rafting trip, not so much, because the guide also died. But the car accidents, they have a lot of problems with right-left discrimination, a lot of problems learning how to drive, making decisions in a quick and orderly fashion is often difficult for many of them. So if they have to go someplace, it helps them to map out the route ahead of time, because if they have to make a left turn at the second green light after the third fire station, it's like, oh my God, I don't know how to do that. So maybe they are at increased risk of having car accidents. They don't know to that. The blue reflects heart disease. So again, you can see heart disease plays a major role in early death in these individuals. Malignancy, we had one patient who died of malignant melanoma, but she was a carrier of BRCA2. And we didn't know whether breast cancer appears to be remarkably reduced in Turner syndrome. It's really hard to find a woman with Turner syndrome who's had breast cancer. We tried to do that study, and we just couldn't find enough patients. And we didn't know whether her having Turner syndrome would trump the BRCA2, and she wouldn't get breast cancer, but she got malignant melanoma, which is also due to that, and unfortunately died. We have a couple of other cancers, multiple myeloma, and adenocarcinoma. This patient actually had 3 different tumors, bladder cancer. So I think that, we don't have enough numbers. You can't make much of these because the N is so small, but still it raises a little bit of concern. And then we have patients who, die. I mean, I think if you die when you're 80, it's really hard to say that was, a shortened life expectancy. What else do we have? Those are the causes. So I think it's hard beyond heart problems. I think it's hard to make a cohesive or coherent explanation for why they die. And the issue of, and I don't have a slide about this, but the issue of gonadal malignancy, if you have a patient who has a Y chromosome, who has Y chromosome material, that patient should have their gonads removed. The occurrence of dysgerminoma or gonadoblastoma is probably on the order of 5 to 8% in those patients. If you look at them, we've looked at, I have the data and I just don't remember it, but if we look at the histopathology of the gonads that were removed in our patients, we get between 5 and 8% actually have tumor in situ, and that's true also in the literature. So some people argue that those are very slow-growing tumors and they're easily removed, blah, 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 blah. But it's, those gonads are not doing these patients any good at all. They're dysgenetic gonads, and they probably should come out if you have Y chromosome material. So here are some other places to read about Turner syndrome. If you go to the literature, this is, if you look in 1970, there were 204 articles about Turner syndrome. If you look in 2011, there were 148 articles. If you look at all of these, you can't read all of these. I mean, I can't read all the literature, and this is what I do for a living. So, there's just too much to read out there. But there are a number of really quite good reviews. This is quite out of date. This is one that I wrote with Elizabeth Macaulay, who's a psychologist with whom I've been working for a long time. Klaus Grabholt has written, Gerald Conway has written. There are a number of people who have written out of Scandinavia, some very nice reviews of Turner syndrome, and some booklets for families, which I really recommend for doctors. For general doctors, if they read the booklets that are written for families, they'll know more than most physicians know, and it's really worthwhile for them to do that. So I want to thank you very much for letting me come and talk to you. I have no idea how to pronounce that except for Tusen Tak. And what I will hope to do is that this is a picture from a medical textbook on Turner syndrome. And this is a classic picture of a patient with Turner syndrome. She has wide-spaced nipples. She has failure of puberty, no secondary sexual characteristics, an increased carrying angle, and she looks really odd. I can guarantee you, if you took me, as beautiful as I am, and you made me naked and you put me in front of a grid, I would look very odd. Okay. But if we actually think about our patients, who are only our patients when they're in the examining room with us, and who are human beings in full right every place else, that what we see is that this is what our patients are, this is who they are. And I ask my patients to send me, I don't take photographs of them anymore. I ask them to send me their favorite picture, because I want to have pictures of them in their lives, because that, when I'm talking, that's really what I want to impress upon physicians primarily, that these are fully formed people, and they have full lives, and everything that we do to them medically has to be in the context of that. For those of you who are distant and who are watching this, if it's being streamed or watching it subsequently, you are welcome to any of the data that I've presented, but please do not reproduce any of the pictures of the individuals. I have permission to use them, but I don't have their permission to give them to you. So to respect privacy, I don't want their faces, I don't want them to Google and find themselves on the web. So please don't use the photographs of the patients. And I'm happy to take questions, and thank you very much for listening.
Thank you so much for sharing your extensive knowledge with us. We are very grateful.
Thank you.
I think we haven't got any questions yet. I have one question from a mother of an adult daughter with Turner syndrome, and she asked, "How come it seems like they have less physical capacity and less staying power, and also needs longer time to recover after physical activity?"
In terms of physical activity, I can't answer that from any, clear-cut data. What I would say is, I don't have, again, anything that we say about Turner syndrome as a group, you have to remember that there are going to be individuals who don't fit that. It's a bell-shaped curve. So if we tell you that girls with Turner syndrome have more problems with math and with higher mathematics and right-left discrimination, I have patients who are accountants and architects and engineers. Okay, so and each individual may not have those problems. I have women who are very active in sports and women who are not. But the reasons I can think that there might be some debilitation would be, number one, is she overweight? Okay, that's the problem with being overweight is the heavier you are, the harder it is to do things, and so the less you do them. Does she have problems, for example, with her knees? Does she have joint pain or problems with instability of her knees, and so that limits her function? Is she actually ill? Does she have cardiac disease? Is there, does she have some decreased cardiac function? You can think about, for example, certain muscular dystrophies. Duchenne muscular dystrophy is more common in Turner syndrome because they are missing an X chromosome. So any X-linked disease of woman with Turner syndrome is more likely to express it if she carries it. But I don't. If you're smaller, you may not be able to. Your pace is shorter, so maybe it's harder for you to run that mile because you have to take more steps. But I can't say that I've seen that as a complaint. But I could think of some reasons why that might be an issue. But I would want to make sure that the child was otherwise healthy before I wrote it off. I don't know. You've had experience. You've had experience.
Yeah, and I agree that very many of the parents, they very often complain that their daughters, they get so easily tired, they won't participate in the trips to the mountains, and even the adults, the women, they say the same. And I just remember one, or maybe we talked about that several times, that she tried to start jogging with her sister. And she tried and tried and tried, but she never could cope. Her sister always ran away from her. And so I also tried to find out, is there something with the muscles or something? And just before coming here today, I had to update my Turner knowledge. And I found...
Me too, I went to bed.
And I found an article from Sarah West from Toronto. I think she's a physiotherapist, so she worked with the physical education. And she said that in earlier studies they had proved that there were altered anaerobic muscle metabolism in the girls with Turner syndrome. So they tried to find if it also was altered during aerobic exercise, and they set up this trial, and they found no microvascular changes in the metabolism in the aerobic, but in the anaerobic exercises, they found this. So the endurance, and I also have read, if I remember correctly, an Italian researcher who had found that their lung capacity differed. It was lower than in women and girls without Turner syndrome. So they tried to find out just the same why Do that tire so quickly.
So for me, I mean, so maybe there is a reason. So for me, this makes me, I want to go back and read all those studies because I want to know how many, what were the numbers and what were the differences.
Of course. Yes.
Then number 2 is, okay, then we really ought to start looking at that and, trying to quantify it and I think we need to quantify things, but you also have to do qualitative stuff as well. And, is that really an issue? And then is it something that you can affect positively, or is it something that you recognize and you say, okay, don't keep up with your sister, jog at your own pace?
Yeah, of course. Yeah.
That's really interesting.
More important to jog.
That's really interesting.
Thank you. Maybe we should...